A short overview, what I'm going to talk about in the next approximately 30 minutes is screening in general. I will point out some points in the Dutch screening program, the challenges that we face, some new techniques like tomosynthesis and MRI, and how their value can be added to future screening. And also, there will be some time for questions. Well, breast cancer at a glance, I will go through it quickly because Professor Lavecchia also pointed out some of these data, and I'm sure today there will be more of this data. Well, breast cancer is the second most common cancer in the world. In 2012, approximately 1.67 million women were diagnosed with new cancer cases of breast cancer. The incidence rates vary. You can see 27 per 100,000 in Middle Africa and 92 per 100,000, for example, in North America. It's the most frequent cause of cancer death in women in less developed countries. In Europe, we see that it's the second most frequent cause after lung cancer. And the lifetime risk of getting breast cancer is approximately between 12 and 13%. I don't think the Netherlands is a very patriotic country, but we are proud of some things next to our windmills and cheese, and that's, I think, the Dutch breast screening program. It started in 1990, and we include all women between the age of 50 and 75 years. The program is secured by the Dutch constitutional law, and the implementation is based on three very important values: quality, affordability, and accessibility for everyone, as much as possible. The goal, obviously, of the screening program is to detect breast cancer in an early stage to improve the prognosis, decrease invasive treatment, and decrease breast cancer mortality. What we see in the Netherlands per year is 14,000 women with invasive breast cancer, 100 men also with invasive breast cancer, almost 2,000 women with carcinoma in situ, and 7,000 of these breast cancers were detected through screening. We have a data monitor that monitors the data and what we do in the Dutch breast screening program. We recently got presented the data of 2015. In 2015, we invited 1.3 million women for the breast screening, of which 1 million women participated. We detected 7,000 breast cancers, of which 20% was a ductal carcinoma in situ. The program sensitivity was 73% and the specificity was 98%. The lives saved per year was 775, and the overdiagnosed people per year, women per year, were 375. The total cost in the Netherlands is approximately 68 million per year, which sounds like a lot, but it's less than 1% of the total healthcare costs. Well, who do we screen? I mentioned it before. Women between 50 and 75 years of age every 2 years with a mammography. I thought to give you some insight about how we report as a radiologist in regular clinics, but also during breast screening. In a regular clinical practice, we need an indication, for example, palpable mass in the breast. For the screening, we don't need an indication because the indication basically is prevention. The second thing we look at before assessing a picture is breast composition. We have 4 types of breast compositions, and I would like to show these to you so you understand the importance to know the breast composition. Here we have 4 different types of breasts. We see breast A and breast D. The difference that you can see right away is that breast D is much wider than breast A. Why is that? Let's look at it more closely. Composition A, this is the breast that is built up of most of all fatty tissue. So there is a little fibroglandular tissue. It must be less than 25%. Well, it says to us that the mammography in these kind of breasts is very sensitive. So you can easily detect breast cancer in these kind of breasts. If we look at composition B, we see some more white patchy areas in the breast. This is fibroglandular tissue. It is between the 25 and 50%, and it's still very well accessible, but it's less good accessible than the category A. We have category C, fibroglandular tissue between 50 and 75%, in which we can miss small masses. So this is already something that you should know as a radiologist when you report on these pictures. Then we have composition D. Sometimes we say we can guarantee this until you leave the hospital. it's fibroglandular tissue between 75% and 100%. And this is less sensitive on mammography. It's very hard to assess actually, and the likelihood of missing something in these type of breasts is quite big. The second thing we look at are the important findings, obviously. Do we see a mass? Do we see something like asymmetry, architectural distortion, calcification? Do we see associated features like breast, nipple retraction or skin thickening in the breast? And if we can compare it to previous images and reports that we have of the women. The less important thing that we do is a final assessment category. And I would like to talk to you about shortly. Some of you might know what it is and others not, so I would like to explain it shortly. It's called the BI-RADS. This is what we put in the conclusion. It's BI-RADS is a shortening for Breast Imaging Reporting and Data System. And we have 7 categories. Category 0, if this is in the conclusion, it means that we need additional imaging to assess the mammography well. So we don't say anything about the likelihood of cancer in this type of breast. BI-RADS 1, it's a normal mammogram. The likelihood of breast cancer is essentially 0. 2, if we report on a BI-RADS 2, we say there's a finding, but it's benign, and we're very certain that it's benign. For example, a cyst, so then we report a BI-RADS 2. 3, then we see a lesion that's probably benign. The likelihood of cancer is less than 2%, but we don't know 100% sure. So we need a short interval period, a follow-up of 6 months is advised. If we report on a BI-RADS 4, which is already more interesting, we say it's a suspicious finding. The likelihood of cancer in a BI-RADS 4 is between 2 and 95, which is quite a big range. So we subdivided it in 3 subdivisions for A, B, and C, which have their own percentages. 2 till 10% is A, 10 to 50% is B, and 50 till 95% is C. If we say it's a BI-RADS 4, you have to take a tissue biopsy. And BI-RADS 5, you basically say that it's breast cancer you see. The likelihood of breast cancer is more than 95%. Well, it's very important to know, within the breast screening, we don't use BI-RADS 3 because we cannot follow up within the breast screening program in 6 months. So it's either BI-RADS 1 or 2 or 4 or 5. And 4 or 5 means referral. This is an example of a referral form that we get from the breast screening program. You see a schematic drawing of the breast in which you see a lesion. Here we note what it is. So in this case, it's calcifications. And then we have the conclusion in which the BI-RADS is used. So we say BI-RADS 1 for the right breast and a BI-RADS 4 for the left breast. So we have a suspicion of breast cancer due to the calcifications. What are the risk factors for screening outside of the program? It's a relative risk above 4. For example, genetic predisposition. If you have the well-known BRCA1 or 2+ gene, then you will be screened outside the breast program. We start at an age of 25 with MRI and add an annual mammography from 30 on forward. And we advise a yearly clinical breast examination as well as a follow-up by a multidisciplinary team. If you have a high familial predisposition, we advise from 35 years to 60 to have a yearly mammography, and then from 60 on you can participate in the regular program, so one mammography every 2 years. And then you have the thorax radiation, for example, in Hodgkin lymphoma or non-Hodgkin lymphoma. If you had it before the age of 40 years, then from 40 years on we advise a yearly mammography. And we also can advise breast screening outside the program when atypical benign lesions are found, or you have a previous history of DASIS or breast cancer, and also dense breast tissue at an older age. It's at an older age, your risks are higher of breast cancer, and as I showed you previously, that when you have dense breast tissue, it poses some challenges with the assessment of the mammography. What kind of challenges do we see within the breast screening? A lot of women find it painful. We're working on solutions. I will come to that soon. Risk for breast implants. This is something that always that we hear, unfortunately, a lot in the clinic, and gives us goosebumps because a lot of women don't go to the screening because they think that there is risk for rupture of breast implants or movement of the breast implant. It's absolutely false. So please don't. Please advise the patient to just go with the breast implants as well to the screening. With the screening, you can have false positives, which leads to overdiagnosis, overtreatment, and obviously higher costs. And you can have the false negatives, which is even worse because basically that's a misdiagnosis. Some solutions, for example, for the painful mammography, there are different pedals now that they develop. For example, the sensitive sigma pedal, you need less compression and you still have a good picture. I think extra courses for radiodiagnosts, we do that in the Netherlands regularly for the radiodiagnosts that make the pictures for the screening. I think there's absolutely an added value there because you can make good pictures without giving very much compression. So that makes the breast mammography a little less painful. Also the tomosynthesis, we will talk about it in a bit, but there are already some studies that showed that with tomosynthesis, the compression halves and also decreases the false positives and negatives, and with that, the overdiagnosis. Another challenge we see, it's more rare, but it's definitely a challenge. Patients with the BRCA mutation that needs the screening outside the screening program and start at the age of 25. This is obviously the age in which they will be pregnant, will be breastfeeding, and this poses a lot of challenges, as well as on mammography, which is already not even accessible at all, and also with the MRI. But also with MRI, we see background enhancement, and we will talk about this in a bit. What we see here is the tomosynthesis. Can we implement this in the breast screening in the near future? Well, let's go back to our conventional 2D mammography. It already exists 100 years, and screening is accountable for at least a 30% reduction of the breast cancer-related death. But there are some disadvantages. And one of this is, for example, the 2D image we make of a 3D structure. Also false negatives and positives because of superimposition. Additional examination is very often needed with extra pictures, ultrasounds, etc. And it poses great challenges in dense breast tissue, and 40% of the women have a category C or D breast tissue. Well, this is just a picture of what we do in the screening. We make 2 pictures of each breast in 2 different angles. How does the mammography work? I will just get my pointer. I hope it works. So we have the X-ray tube, we have the detector plate, the compression plate, and in between the detector and the compression plate is the breast. Then we have X-rays and we make the picture. If we look at the tomosynthesis, we again have the detector plate, the compression plate, and the breast in between, but now the X-ray tube, it rotates in a certain angle, which gives us many pictures from different angles, which helps us assess the breast. Well, what is the difference in a sense? Here we see a schematic view of a mammography. We see a speculated lesion that's probably breast cancer. Then we have, for example, this round, which is dense breast tissue. If you make a mammography, here you see images, but they're superimposed, so you can miss the speculated mass actually in the breast. What does the 3D tomosynthesis do? It makes pictures from different angles, which in some pictures will pose the same problem, but we have the additional pictures with different projection in which you can see the mass. So this is, in short, how it works. We get the raw data, and the raw data are the multiple pictures, so the multiple slides of the 3D tomosynthesis. From this, we make a reconstruction, so we have a 2D synthetic mammogram. This is easy because it looks a bit more like our previous 2D normal regular mammogram, and it's at one glance you can assess the whole breast, and then if you have doubts, you go to that area in the tomosynthesis. It is very important not to use either the synthetic mammogram or the tomosynthesis, but to use them together. You have to look at all the pictures, so all the pictures you have to go through. The sensitivity and specificity of the conventional mammography versus the 3D tomosynthesis, we see that the sensitivity is 89% and the specificity 72% of the conventional mammography. And in 3D tomosynthesis, we see that the sensitivity is 90% and the specificity is 79%. So that's a lot higher. The sensitivity increases with both if there is less dense breast tissue or if they're old exams to compare. The dose, Teertstra et al. And Swan et al. Did a lot of research about the doses of mammography versus tomosynthesis, and per direction, it's not a significant difference. I want to show you an example of a problem that we can see in the clinic, and I hope my video works. What we see on the left picture, on the left picture view, is conventional mammography. You see very dense breast tissue here; it's all white. Then we made a compression of an area we suspected, and we still see dense breast tissue. So we're still not sure yet if there's something, if that's a distortion or not. Then we have the synthetic mammogram that we make with the tomosynthesis. Still here in the prepectoral area, we see this denser area that we don't know. Now we have the tomosynthesis, and it's a video, so we will go through. So try to focus on the prepectoral area if it goes. I'm not sure if this, no? No, I don't think it yeah, it is? Okay, perfect. Well, what we actually see, then I press on it a few times, what we actually see is that in the prepectoral area, you see the mass, but it's composed of different layers. So it's breast tissue superposed, and there's no really voluminous mass underneath. So we just let this patient go. What are the advantages? There's better evaluation of location, size, and multifocality, because you can go through the pictures. There's less use of Byrod's tree, which if we extrapolate it to future screening, then you have to refer less patients. There's a decrease of additional imaging. Also, within screening, this would mean less referral of patients. There's better detection of lesions in dense breast tissue, and there's a decrease of false positives and false negatives. But there are also some disadvantages. The assessment time takes longer because there are more pictures to look at. The scan time is longer. It varies between 3 and 25 seconds. It's with different manufacturers, it's different. There's a bigger storage capacity needed for the pictures, so this also increases the cost. And there's a learning curve for radiologists. What else can we have in the future of breast screening? I'm not sure if X-ray vision glasses will come anytime soon. So let's hope for the breast MRI. In general, what are the indications to do a breast MRI? Well, obviously, the identification of breast masses that we cannot see on the mammography, staging for therapy, evaluation of the response to therapy, identification of recurrent malignancies, screening in high-risk patients, and the evaluation of breast implants for rupture and malignancy. This is how the woman is positioned. So the patient goes in prone position with the breast in the breast coil, so with different sizes. What are we looking for in a breast MRI? We use an intravenous gadolinium contrast agent to visualize breast lesions. They enhance, or we hope they enhance. This is based on the pathophysiology of angiogenesis. So in tumor, we think there are more blood vessels, and the permeability of the vessel wall different. And benign lesions in breast tissue can also enhance. So this is important, and this poses some challenges in the breast MRI. How do we evaluate breast lesions after contrast admission? In 1999, Kuh et al. Analyzed 3 types of curves, curve 1, 2, and 3. And what we need to know of this graphic is that if you see a curve 1, it's highly likely to be benign lesion. If you see curve 2, there can already be a suspicion for malignancy, but it still can be benign. And if you see curve 3, it's highly likely to be malignancy. We have also the color-coded graphic. Here we code type 1, so benign curve blue, type 2 is green, and a type 3 malignant curve is red. This is important for the computer-aided detection system that we use within the MRI. What is this? It's nothing but a software that displays the enhancement curves per pixel in time with a color map. I will show you an example. Here we see an MRI of a breast lesion in the left breast. What we see at the 2-1 is we see an architectural distortion here. On the T2 actual images, we see iso to hypo intense area if you compare it to breast tissue. On the T1 contrast enhanced sagittal views, we see a breast lesion with rim enhancement. That is obviously very positive on our PET MRI. And if we see the computer-aided detection map that we use on this, we see the breast lesion mostly red. And if we look at the graphic again, this is the malignant curve. So this is how we see a breast lesion with the CAT program. What do we look at if we find a lesion? What kind of characteristics do we look at? If a lesion enhances, we look at three things. What kind of lesion is it? Is it a focus? It's an area of less than 5 millimeters. Is it a mass, or is it a non-mass-like enhancement? And this can have different types. We're going to look at it a little bit more. If we see a mass, the first thing I look at is the margin. So is it circumscribed, is it obscured, microlobulated, indistinct, or spiculated? When we have a spiculated mass, it's highly likely to be malignant. But if it's circumscribed, it may be a lymph node or a fibroadenoma, which is a benign lesion. The second thing we look at is the shape. Is it round, is it oval, or is it irregular? Here again, when it's irregular, then it's highly likely to be malignancy. Enhancement, there can be different types of enhancement. You can have a homogeneous and heterogeneous enhancement. There can be rim enhancement, as we saw in our example before, enhancing septae and central enhancement. This is an example of a irregular spiculated lesion in the breast with heterogeneous enhancement, and this was an invasive carcinoma. If we look at the non-mass enhancement, you have different types. Non-mass enhancement is usually seen with adasis. So you can have different types, linear and ductal, because sometimes daces obviously follow the ducts. Segmental, which is a bigger area. Regional, it's even more, and diffuse is the most widespread area. And this is, for example, a non-mass enhancement that's linear, so probably a ductal pattern. And then we look at the kinetic data, but we already discussed this. It's sort of curves. I want to show you two cases. We start with case 1. It's a woman of 56 years of age with no familiar or genetic predisposition, and we did an MRI because of the dense breast and the inability to assess her breast mammography accordingly, or that was what the radiologist thought. So here we see the mammography of 2013 and 2015. So this is 2013 under, and above it's 2015. We see dense breast. I think it's a category C. Some asymmetry, but it was in the breast tissue, but it was already there in 2013, and I don't see any suspicious masses. Then when we look at the MRI, there is a diffusion weighted imaging that we use just to explain it really shortly, because it's obviously a big subject, but to explain it very shortly, water molecules have a Brownian motion, which is a certain motion that the molecules make. And when this is restricted, so within a tumor, for example, it shows on the diffusion restriction series as a restricted diffusion, which is suspicious. The subtraction series that we see here, and I have an enlargement of it, so you can see the lesion more here. What we do with the subtraction is you have enhancing lesions, but you have also lesions that are high dense, so wide, before contrast administration. So you withdraw these two from each other, and then it leaves you only the lesion that enhances after contrast administration. So we saw this lesion, which also has some irregular borders. We don't trust this at all. And then we have the color-coded map. We see different colors, but mainly red. And if we put the graphic next to it, it's again a malignant lesion. Something that I'm very enthusiastic about, and some of my colleagues as well, is the fast sequences on the MRI. It's on the 3 Tesla MRI, and I try to explain it to you shortly and as easily as possible. What we look at is the enhancement of the aorta. When the aorta enhances in these sequences, we say the time is 0. After time is 0, we look at different time frames. Every time frame is 4 seconds. So here we see first time frame. T is 4, so there is, I can't really see it, but if it's good, you see here the lesion already enhancing a little bit. So in time frame 1, this lesion is already enhancing, and then in time frame 2, which T is 8 seconds, then you see it enhancing even more. These are obviously some pictures made of a dynamic series, so I will show you the video of how we see it in the clinic. So try to look at where we saw the breast lesion here. And this is really kind of how fast it goes in the clinic. And there are theories that if the breast lesion's enhanced in the first, second, or third time frame, that the likelihood of malignancy is very, very high, and we have good reasons to believe so already within studies. So if this could be the case, and if this fast sequence could give us the information we need about breast lesion, and we can implement this in the screening, it would be great, because the assessment time would be very little, and also the scan time of the fast sequences are much less than a normal MRI. With this case, we did a target ultrasound after MRI, in which we saw the lesion. We did biopsies afterwards, and the pathology resulted in invasive ductal carcinoma grade 2. Our second case is a woman of 64 years, and she got a referral through the breast screening, and you will see why. We have the mammography of 2013 here, 2015 here, in which we see the breast lesion. It's very clear, I think, for everyone to see that there's something new came. It's a irregular mass with spiculae. It's highly suspicious of a malignancy, so I would say Byrod's 5 here. When she came to our clinic, we made a compression of the area, and within this area we see next to the mass also some calcifications. You see them here, and also here widespread, and this could mean that there's a ductal carcinoma in situ on top of the invasive component. With ultrasound, this was the lesion we saw. As you expect from a Byrod's 5 lesion, you expect it to look like this. This is typical for breast cancer. We took biopsies. In the biopsies, we see calcifications. And then we get to the MRI. On the T1 axial views, we see a big architectural distortion. On the T2, it's iso to hypo intense areas compared to other breast tissues. We have the diffusion restriction map here. I can't see my pointer. There's diffusion restriction. That's all you need to know. And on the PET MRI, it's obviously very positive. If we look at the color map and we put the graphic next to it, I think you can also see that this is a very malignant lesion. And in the front, you have a linear area that is the area what you saw of calcifications in the mammography. Here again, we go to the 3 Tesla MRI to the fast sequences. I will show you first like this, and then again the video. T is 0. This is time when we see the enhancement of the aorta. Then T is 4. It's the first time frame. We already see some enhancement here of the lesion. So it already enhances in the first time frame. Then it enhances some more in the second time frame, and even more in the third time frame. So if we look at the video, we will see the same lesion in the left breast, enhancing here. You see also the arteries going there. So we think that this might be something we can implement in the future in screening. Well, we are very hopeful for this. The pathology showed an invasive ductal adenocarcinoma grade 3, which means the very aggressive, with a ductal carcinoma in situ. Those were the calcifications you saw. In the Netherlands, we have a DENSE trial. What we do in the DENSE trial, it's a multi-center randomized controlled trial. And who we include are the women with a category D, so category 4 breast tissue that had Byrod's 1 or 2, so a negative screening. So they were not referred to breast centers because there were nothing seen. So we are trying to see whether in these patients we can see malignant lesions that are basically missed in the intervention group. The intervention group will receive the 3.0 Tesla MRI that we just saw with the fast sequences, and the control group will just be in the regular mammography. We hope to have some results in 2018. The take-home message. I hope, and I think that's very likely to happen, that the tomosynthesis will be implemented in the screening. I know for the Netherlands for 2018 they already ordered some tomosynthesis systems. Hopefully the 3 Tesla MRI will have a place within breast screening in the near future, and then especially within the group of the dense breast, because we know that we miss breast cancers in there. Please know that you can participate without risk to the screening when you have breast implants, and I think that the main focus should be that we all stay committed to keep on improving the breast cancer screening programs.